Thank you for your interest in corneal neuropathic pain. I gave this lecture to the Chippewa Valley Optometric Society in the spring of 2019. I can't say that I'm super proud of it, primarily because I tried to squeeze a 2-hour lecture into 1 hour. I mispronounced words and I rushed it and I definitely truncated the conclusions, but it is what it is, and I'm hoping you'll find it useful in your treatment of patients with dry eye symptoms. I have a couple comments at the end as well. My name is Doug Stein. I have a practice in Wausau. I worked at Chapel for 17 years and went into private practice 20 years ago with my wife, who is responsible for our success. The only thing unique about our practice is we don't take any vision plans, so it's mostly Medicare and disease patients. Our setup is 7 exam lanes and 3 screening rooms and 2 docs. And I work 3.5 days a week, and I'm trying to get down to 3. You're probably wondering how a guy from Wausau would wind up with a speech on neuropathic pain, and I'm going to blame my daughter, Gabriella. In 2010, I bought an OCT, and it took about 2 OCTs to figure out that thing was smarter than me. So I spent the entire winter of 2011 studying retina, and I learned a ton. And when you get to be an old guy like me, you fall asleep early and you wake up at 5 o'clock in the morning and you can go through another news cycle or play Words with Friends or Sudoku or whatever. So I said, you know what? Every winter I'm going to pick a topic, I'm going to study it front to back. So 1 year was glaucoma, but we've all been looking at glaucoma for 30 years. Well, for me for 30 years, for you guys since the beginning of your optometry career. And when you read an article on glaucoma, you already have a framework of understanding of how it works. So if it's narrow angle, the article's narrow angle, you put it there. If it's SLT, you put it here. So you already know when you read the article how it's going to fit and how you're going to do it. When I got to neuropathic pain, it was such a new topic for me, I had no idea where it was going to lead. So I'm whining about this to my daughter because I'm finding these articles and nothing seems like it's making any sense. So she says, Dad, if you push alternate print screen, you can grab whatever's on the screen and you can put it in a file and you can come back to it later and arrange it in a fashion that makes sense. I said, apparently I was the only person on the planet who didn't know that. And so that's how I wound up with these PowerPoint. And the file she uses is PowerPoint online, and PowerPoint online you can get to from any place. So if you're in Colorado watching my son ski, and I'm up at 4:30, not 5:30, because it's hour shift in time. So then you can, whatever articles you can find, you can stick in the file. And the 2 groups are the patients that come in and tell you that their eye feels terrible. They have all these artificial tears, and they've had Lipoflow and Xiidra. They've had Restasis, they've had doxycycline, they've got all the treatments you can think of. And you look at the front of their eye, it looks absolutely fine, but they're absolutely miserable, and they wake up in the middle of the night, they're using ointment in the middle of the night, all this is going on. Then the other group are patients that show up, the bottom half of their cornea looks like hamburger. It looks absolutely terrible. Their only complaint is that by the end of the day, it gets a little hazy, and it's probably because they're looking through this junk on the front of their eye. And so my mission then was to figure out how these 2 patients can even exist. So I started reading all of the dry eye things, so I knew it had to have something to do with the way people feel. So I started researching pain. So association between dry eye and signs. So this is an ophthalmology article. Conclusion, associations between dry eye symptoms and clinical examinations are low and inconsistent. Dry eyes and migraines, is there a correlation? Irritable bowel syndrome and dry eyes, how does that work? Eye pain and dry eye in patients with fibromyalgia, symptoms of dry eye and depression, an unbelievable number of other painful situations that go on in people's bodies. Dry eye post-traumatic stress disorder and depression, dry eye suicidal ideation. Here's an optometrist, this is Jimmy Bartlett. Conclusion of this article, this was 2015, associations between dry eye signs and dry eye disease symptoms are low and inconsistent. New study finds omega-3 fat acids ineffective in treating dry eye disease. But what they used for success on determining whether it was successful or not, dream study results refute how long belief that omega-3 oils reduce dry eye symptoms. And we have to talk about that. So this is the lecture outline. I want to talk about normal pain, and it's going to be a review for you guys. I just got out of school, but some of us have been around for a long time. This will be kind of relatively new stuff. And normal pain is nociceptive pain. It's created by nociceptors, which are the pain receptors that detect nauseous stimuli. We're going to talk about neuropathic pain, and neuropathic pain is pain generated not from tissue, but from nerves. We're going to talk about central sensitization. Central sensitization is brain pain, and it's pain that exists without stimuli of the peripheral nerves. We'll talk about pain treatment, and we'll talk about, I'll throw some eye stuff in there too. So what's a nociceptor? Nociceptors are relatively unspecialized nerve cell endings that initiate the sensation of pain. Nociceptors are cutaneous and subcutaneous receptors specialized for the detection of harmful stimuli. That's what a normal, and so normal pain is created by nociceptors. There's 4 ways we take information in our entire bodies. They're chemical, temperature, pressure, and light. And I know this is an eye group, but we're going to skip light altogether. So this guy steps on a acid-covered, burning hot, 15-centimeter nail, and it goes right through his foot. The nociceptors fire like crazy, all 3 of them. They send this signal along the axons that wind up at the spine. The first synapse is at the spine, where the spinal thalamic tract is. It goes up to the thalamus, where you recognize pain. There's some of the fibers will split off and head over to the homunculus, so you can tell where it is. Then you process the pain. There's a descending pathway as well. Let's look at it a little closer. There's 3. They broke this into hot and cold, but it's temperature, acid, and mechanical. The transduction channels cause the end bulb to depolarize, which sends the message along the axons to the spinal thalamic tract. The axons come in 2 versions, myelinated and non-myelinated. The myelinated are the A's. The C axon, there's only one of them. The myelinated come in 3 versions, the A, alpha, beta, and delta. Alpha and beta axons send information regarding proprioception and touch, and the A delta sends mechanical and thermal pain. The C fibers, which are unmyelinated and much, much slower, send the signal of all 3 of the nociceptors. So you've heard of small fiber neuropathy. Right near the nociceptors, the fibers are relatively small, and when they get closer and closer together, not only nerves that are sensing nerves, but also motor nerves go past one another. All the motor nerves are myelinated, and so that when it gets to the spine, the motor nerves come out the front, and the sensory nerves go in the back on the dorsal side, and this thing is called the dorsal horn. At the dorsal horn, which is where the first synapse occurs, this one shows the pain receptors, the C fiber and the A delta fiber. If I had here's the different shapes of everyone's familiar with this. So that's the ascending pathway of pain. So here's a guy that steps on the acid-covered nail. There's also a descending pathway of pain. And the descending pathway of pain is how you interpret the pain and how you respond to it. And you can actually control the signal that gets through to you, to the thalamus, through the descending pathway. The concept front to back then is there's transduction at the transduction channels, the transmissions in the axons, the modulation as it synapses at the spinal thalamic tract and goes up. Perception is in the thalamus. Interpretation is where it hurts in the homunculus, and then the downward pathway is the behavior, how you're going to respond to it. So if you're in a stare-down contest with someone and it starts to hurt, you choose to ignore that pain because you're going to win, right? I mean, that's what that's about. So is there anything like this in the eye? Yes, and all of these pictures are stolen from the DEUCE-2 study. There are 4 pain receptors, nociceptors in the eye, and they have the different transduction channels on it. The mechanical, which is the foreign body one, where you get something in your eye, you can really feel it. That one fires like crazy. There's a multimodal one, and then this one, these 2 down here are cooling and dryness and chemical, and they're both chemical and cold. The thinking is that if you use the normal concept that we have of an oily layer and a watery layer, and then the mucin layer, and then the nerve endings right under it, when the oily layer breaks down, the watery layer evaporates, and immediately it cools off. So you get a cool spot. And then right as soon as it starts to get cool, also there's a lot less water and the same number of chemicals, so you wind up with hyperosmolarity. So there's hyperosmolarity detectors, and there's also cold detectors, and these 2 detectors control the blink reflex. The signal goes from the corneal nerve plexus to the trigeminal ganglia, the same as it does every place else in your body. It goes into the spinal through the dorsal horn, where it synapses and goes to the spinal thalamic tract. There are nerves that split off from that location to create the blink reflex, which is in this area here. And let me just tell you about that for a second. Recently, Dr. Wu showed a linear increase in blink rate with increasing air flows applied on the ocular surface. This stimulus enhances cold therapy thermoreceptor activity, thus favoring the interpretation that spontaneous blinking is maintained at least in part by the continuous nerve impulse firing of corneal cold thermoreceptors. Lacrimation, cold thermoreceptors. Considerable evidence suggests that involvement of the 2 classes of cold thermoreceptors, both in regulating tear formation to maintain adequate moistness of the ocular surface and in generating the sense of irritation produced acutely by excessive drying of the ocular surface, the ability of corneal cold thermoreceptors to detect relatively small changes in both temperature and osmolarity makes it likely their primary role is to detect changes in the tear film produced by evaporation, and thereby creating they create the reflex that creates the tears. Does that make sense? And I stumbled a little bit there, but you guys are so bright. You saw what I was doing, right? And then this talks about how the neuron breaks off and goes to the other areas. So here's my friend who steps on the burning hot acid-covered 15-centimeter nail, and you'll see that not only is it red and inflamed exactly where the nail went through, but that entire area surrounding that also winds up red and inflamed. Why does that happen? And it's because the vascular system gets involved. When something gets red, what happens is the vessels dilate, they get real leaky, white blood cells can leak out. White blood cells have inflammatory modulators. They also release molecules that cause the transduction channels to be more sensitive. So not only is it painful exactly where the nail came through, but the entire area around it becomes painful, and that's called hypersensitivity. And that's what this is about. The normal pain response is this area here. When you damage the tissue nearby, you wind up with hypersensitivity. Let me describe that just for a second. There's 3 devices to measure pain, the same as there's 3 nociceptors. And this is the mechanical one. The temperature one is just something they put on your hand or wherever they put it, and they raise the temperature slowly, and you'll tell them how much it hurts. And then the chemical one is like eye drops or capsaicin or like hot peppers. That's how they test the chemical portion. So the pain measuring tools follow the same nociceptor area. So this guy got burned at A and D, and then they come back later and they push on it to see how much it hurts. Well, before they burned it, it took a lot of push before it started to hurt. That's a measurement of 14 foot-pounds. After you burn it, it hardly takes any pressure at all before the patient recognizes an equal amount of pain. What is that called? That's called hyperalgesia or allodynia. So the blue line is the normal pain response. The red line is after it burns. The part down here at the very bottom in red is something called allodynia. Allodynia is pain that exists at a threshold that it didn't exist at before. Does that make sense? So allodynia is the perception of pain at a stimulus that's below what was the preset, at the level of the preset. Does that make sense? This red line can shift both directions. There are reports of people getting shot in battle or spraining their ankle or having some injury, but they're so concerned about what's going on in the battle, they don't notice till later that they've been injured. So that red line can move in either direction. Do we have anything like this in eye care? Yeah, so people with iritis, they're not normally photophobic, but their eye is just killing them when they come in. Even normal lights are bothering their eye, and that would be photoallodynia. Then we also have patients that usually it's a 22-year-old male construction worker who's as rugged as the day is long, and you know how you put your BIO at about the same illumination on every single patient, and and you put it in, you don't really change it, and you look at 100 eyes in a row, you don't have to really change it, and you look in this guy's eye and he just about flips out, he jerks his head to the side, and he grabs it, kicks his feet on the chair. So is his pain real? So I'm going to read this to you. The British Medical Journal reports a nail penetrated the shoe of a 29-year-old construction worker, causing great pain. A builder aged 29 came to the accident emergency department having jumped down on a 15-centimeter nail by chance. As the smallest movement of the nail was painful, he was sedated with fentanyl and midazolam. The nail was pulled out from below. When his boot was removed, a miraculous cure appeared to have taken place. Despite entering proximal to the steel toe cap, the nail had penetrated between his toes and his foot was entirely uninjured. The question is, was the pain real? As the doctor, the pain is real. You can't tell someone they're not in pain. You can't experience somebody else's pain. So that kid, I've been at this for 37 years, and for 35 years old, when I put it in, I'm kind of roll my eyes. Come on, you visual wimp. I don't say that out loud, of course, but that's what I'm thinking. But if he believes that that's painful, it's painful to him. So I'm so sorry that this is bothering you. I'll make it as dim as I can, be as considerate as you can, because don't be a jerk like me for 35 years. If someone tells you that it's painful, it's painful. Their perception of pain. Now, we need to know some things about pain measurement scales. Everyone knows the 1 to 10 thing. There's a scale. We have a pain measurement scale that's directly toward the dry eye. That's the OSDI. There's a new one that has to do with neuropathic pain, and this is the OPAS, and there it is right there. And I'm trying to get done. I'm afraid of getting this too soon, so I'm going to go through here quickly. There are a ton of nociceptive pain control techniques. I'm going to spend 2 minutes on a topic that people spend their whole lifetime learning, and essentially what I want you to know for this is that every time there's a synapse, there's a neurotransmitter, and every neurotransmitter is a chemical, and every synapse is our opportunity to interfere with the pain signal as it goes along the system. And this kind of describes which drugs work at which location as it goes up. I want to spend some time in a second at this location right down here. So this is the descending pathway. That is the first synapse where the spinal thalamic tract starts. So at that location, we have a myelinated nerve coming in from the top, so there has to be an A delta nerve going to the dendrite at the end of the nerve, and then that nerve will become the spinal thalamic tract. The other side is the descending pathway that's coming from above. The descending pathway controls the pain by inhibiting the ability of that synapse or that dendrite from firing and causing an impulse going up the axon. The neurotransmitter of the excitatory response synapse is glutamate. The inhibitory synapse is GABA. So the drugs gabapentin and pregabalin work at that location. They try to inhibit the signal of the pain at the level of the spinal thalamic tract at the first synapse. And I bring this one up because if we start treating neuropathic pain, this is probably one of the safest and best bang for the buck drugs that would be available to us. So, and that's how it works. We need to know about the gate theory of pain. So when I go hunting with my buddy Greg, I carry the candle out to the back of the truck and I'm putting it in there, and I never remember to take the hitch out, and I smash my shin into the hitch, and because I'm using the transmission transduction, I don't drop the thing. I carefully observe my behavior and put the candle down. Then I jump around like a madman, say some really vile words, and rub my knee like crazy, my shin like crazy. Why do I do that? Does it do any good? And the answer is yes, and it's based on the concept called the gate theory of pain. In the gate theory of pain, the A delta and the C fibers are sending this incredibly powerful pain signal directly to your brain. And this is my version of it. And this was the original picture from 1966. I mean, this is 65. This is a long time ago when these guys first came out. And if you look at the gate theory of pain now, I mean, it's like this huge graph. But this makes as much sense as any. The spinal thalamic tract is only so big. So if you can crowd the pain signal out by sending some heat from proprioception and some touch signals with it, you can decrease the pain, and that's called the gate theory of pain. Is there anything like this that we do? Yeah, my wife's a dental hygienist. When she works, she doesn't do dental hygiene much, but when she works, she hunches like this and she winds up with painful shoulders. So I get this China gel and I'm rubbing it into her shoulders, and I create the massage, and it decreases the pain by the gate theory of pain. You guys are familiar with capsaicin. It's used in neuropathic pain for patients who have ophthalmic zoster, post-herpetic pain. I'll apologize for these pictures, the best I could find, but they're pretty good. What's a TENS unit? A TENS unit is a transcutaneous electrical nerve stimulator. It decreases the signal of the A delta and the C fibers by stimulating the other two fibers that creates that vibration. TENS units decrease pain through the mechanism called the gate theory of pain. Anything we do like this? Yeah, when people get ocular headaches, you'll see them rub their head. We put cold compresses on itchy eyes. Does the cold compress decrease the itch? Yes. Does it decrease the histamine or the other things that are causing the itch? No. But it decreases the signal, so you get the perception using the gate theory of pain that it's more comforting. Does that make sense? Cold eye drops, people rub their eyes. So that was all of nociceptive pain. I don't know how long that took. So neuropathic pain is pain that comes from the nerves themselves, not from the tissue. So the easiest way to understand it is people that don't have a limb. So if you don't have an arm, there are reports of people who can feel their fingers are hot, like they dipped them in hot water, that there's water running on the back side of their hand. Sometimes they feel like their hand is stuck in a clench that they can't seem to let go of. And that's not actually happening. The problem is the nerves are sending that signal to the brain. That's kind of the easiest way to explain neuropathic pain. Is there anything in eyes that are like this? There are reports of patients who have had their eyes removed who will still have a foreign body sensation. Their eye will feel dry. Charles Bonnet syndrome, where patients who were once sighted are now blind will see these relatively pleasant images in front of them. That is a type of a neuropathic event. And neuropathic pain isn't always pain. It's the rain, it's the clench, I would like to come up with a better word than neuropathic pain, but the word pain for me covers all of those sensations, okay? So it's described as pain with no biological value. There's two classifications. There's peripheral neuropathic pain that comes from damage peripherally, like postherpetic neuralgia is generated from the cells that are the nerves that are damaged. Sometimes that pathway becomes so intense for patients that they centralize the pain, and that's called central sensitization, and that's a central neuropathic pain. All of neuropathic pain is caused by damage to nerves, and it can be through surgery, chemotherapy, infection, injury. Diabetes is a big thing. You see advertisements for Lyrica all the time. If you watch 60 Minutes, apparently a lot of people that have 60 Minutes are diabetics, and they talk about diabetic neuralgia. So what type of pain is it? I have a video, and I'm only going to let it go long enough to make everyone nauseous. This is a woman who has trigeminal tic de Leroux, which is trigeminal neuralgia. And in this case, what happens is a blood vessel presses on the trigeminal ganglia, and it creates an image in her face of pain that is just beyond comprehension. She was kind enough to, can you make this work for me? She was kind enough to put this on a video. I want to tell you before we start that there is a follow-up video where she was treated and she's back to normal. But I'm going to let this go for, I'm trying to get done quick, but it's pretty important, so I'm going to let it go for a while.
Hi. I haven't actually filmed or spoken about this since it started. I sort of have been trying to hide it from my family. Well, to protect them, because I don't want them to have to suffer to see me suffer. Especially my youngest daughter, because she's very affected by what I go through. I'm having attacks right now. I'm trying really hard to just get through it, and then just sort of go about my stuff, trying to stay busy. The last 3 days has been really bad. I also get migraine headaches with it. So, I mean, right now, the whole right side of my face feels like it's on fire. I sometimes say it feels like I have like I have thousands of fire ants crawling in my face. And my teeth, it's usually the top teeth, but lately it's been happening on my bottom teeth as well. It feels like someone's poking something hot right into the nerves of my teeth. I also feel like right here in the back of my ear, like someone's jabbing like a poker, something. And it goes up towards my eye also. My face also is very numb. Sometimes I feel it's sometimes swollen a little bit, but right now it's not. The last few days, the pain has been pretty bad. It comes and goes every couple of minutes. Sometimes they last like 20 seconds. Sometimes longer.
Have any of you ever seen a patient in neuropathic pain? The answer is yes. The studies show that between 5 to 20% of the general population suffers from neuropathic pain. I like this slide because it differentiates between chronic pain and neuropathic pain. Chronic nociceptive pain, if you don't have a meniscus and you walk on it, nociceptors are going to fire like crazy and let you know you shouldn't do that. So that's a pain that's teaching you something. Neuropathic pain is nerve pain. So between 5 to 20% of the population in this study, it was a collection of studies. Some of you are thinking, well, why haven't I heard of this before? This is an article, 2014. This is the first systemic review of epidemiological studies of neurological pain in the general population. The first review. They were able to find only 21 articles on neuropathic pain that reviewed the number of people that had neuropathic pain from 1966 to 2012. Most physicians are unaware of this. When I have physicians as patients, I quiz them about central sensitization and neuropathic pain, and they refer them to the pain clinic, and that's the extent of it. So the best estimate for this study was between 7 and 10% of the population. So not everybody gets that same pain that gal had. A lot of people will get other portions of pain, but it's not pain. There's neuropathic itch. So only 3.5% of people wind up with itchy pain. There are reports of people, well, I have a friend whose daughter had one of the leukemias, and in her treatment, she wound up with a peripheral neuropathy because it creates small fiber neuropathy. Her legs would be so itchy, she'd wake up in the morning and they were bleeding because she would just scratch her leg like crazy. There's a report of a woman who had such horrible itch, she rubbed all the skin off the back of her head. They put her in an institution, put mittens on her at night and taped them on her wrist to try to keep her from doing that. She woke up one morning, she had this sticky stuff in the back of her head. She went to see the physician and she had scratched through her skull and it was cerebral spinal fluid. This is not the same as normal pain. Numb pain. What is numb pain? She said it's numb down here. Her whole face is on fire, but there's a numb spot. So my clinic is next door to a walk-in clinic, and they send us a bunch of patients with herpetic, with ongoing zoster. And so a lot of them become our patients over the years. And so I'll always quiz them when they come back in. Do you have any sensation loss or any problem up that? And the guy says, well, and they always say no, because they've adapted to it. They say, well, you know what? If I put my finger right here, I can feel my finger. And then as I move it over here, all of a sudden, I can't feel my finger because it's numb, but it hurts like the devil between here and here, and then I can start to feel my finger again. So I was thinking, that's a numb pain, right? That's kind of what he's describing. And I was trying to think, how could it possibly happen? And possibly, and I don't know this because I'm not a pain guy for sure, maybe the A alpha signal that's on the axon winds up crossing over with a C or A delta signal further down. So he's getting the touch, but he's perceiving the pain. By the time the signal gets from here to here, it's a pain signal, it's not a touch signal. Does that make sense? I had a guy in who was stage 4 melanoma. he came in because he couldn't see. It was like 20/60 in one eye and 2300 in the other eye or worse. And when I would talk to him, he never blinked the entire time I talked to him. And I said, well, what else is going on with you? Man, we're talking about the Packers and the weather. He doesn't blink the entire time. So I take a look at his cornea, the bottom half of his cornea. You ever seen a Dallin where, between a contact lens and a pterygium, there's a spot that never gets wiped, and you get this big divot? I'm sure you've seen them. The bottom half of his cornea looked like a giant Dallin. His normal thickness cornea, then just collapsed. So I put him in a bandage contact lens in each eye, and he was already 20/30 in the better eye, and he's still 2400 or whatever in the other eye. And in about 3 days, he was about 20/25 in the lens with the one bandage lens, and I had to wear him overnight because he wouldn't close his eyes at night. And the other eye didn't get any better. I finally put an amniotic lens on it, and 2 days later, it was absolutely miraculous how that eye had changed. And the thickness had come back, and he was about 20/30 in that eye. But he told me he couldn't feel his hands up to his elbows, and he couldn't feel his feet to his knees. And that's the poisons that we use to treat cancers cause neuropathies. Which antibiotic causes the most neuropathies? Fluoroquinolones. Fluoroquinolones are notorious for peripheral neuropathies. So I'm hoping that no one's using fluoroquinolones, at least as a first-line drug. Tingling pain, burning pain. So when I say neuropathic pain, I don't mean pain every time. You know what I mean? I'd like to come up with a better word than pain, a neuropathic something. Have you ever heard of Morgellons disease? Awesome. You're the first person I ever met that knew anything about Morgellons. So Morgellons patients have the perception that fibers are growing out of their skin. It's self-diagnosed. There's no ICD-9 and when they tell their physician that the fibers are growing out of their skin, they refer them to psychiatry and psychology and my first patient that I learned about this when I first started my private practice. I had a lot of time on my hands. There were that many patients. So this guy comes in, he's got fibers growing out of his skin. I said, that's awesome. I had a camera. Grab him with a piece of tape and put him on a piece of paper. I'll take pictures of him, and then you can send them around, see if there's any commonality. So that I got plenty of time. I had no idea what it was that long ago, but Morgellons must be a neuropathy where people think something's under their skin and they're picking at it. And they pick at it till it bleeds or leaks, and then a fiber sticks to it, and their perception is that that fiber is growing out of that wound. And I used to think it was just totally outlandishly rare because I had never seen it for years and years and years, and then the internet showed up, and then I could study this kind of thing. And I'll see patients, I probably see it every other year now, and the way they present is, you ever seen meth addicts on when they show, we arrested this woman, she's meth, they get blemishes all over their face and that kind of thing because they have a peripheral neuropathy and they're picking at their skin. So a patient will come in that I hadn't seen for a while, or that for a new patient, and I'll look at them and they'll wear long sleeves and they'll have these little pick marks on their skin. And I don't ask them if they have fibers growing out of their body because they already told somebody else, and they're not going to tell me that because the last guy sent them to a psychiatrist. So you talk about the weather and you talk about the Packers, and then you get them relaxed. Do you ever experience any like creepy feeling on your skin? Yeah, I do. You ever pick at them? No, and they'll be picking at it right in front of you. So when you see somebody who presents like that, don't ask them if they have fibers going on the skin, but sneak up on them and see if that's what's going on. And you've seen people like this. Patients come in and get those pick marks all over, right? Anyhow, so there's a bunch of neuropathies. Phantom limb signature diabetic peripheral neuropathy, we're going to talk about that. Tic de la Rue, we already talked about. Post-herpetic neuralgia. This is complex regional pain syndrome. It used to be called reflex sympathetic dystrophy. There's two types, type 1 and type 2. But I think there's only one type. The type 1 is where there is a confirmed crush injury before the symptoms present. So it's a sprained ankle or a sprained knee, or they get actually crushed with something and it damages the nerves. Then there's surgically induced neuropathic pain. We're going to talk about this. So this is complex regional pain syndrome. This is an example of some of the the body's response to it is just way out of proportion to the disease. The downward side of the pain cycle doesn't occur. So can you make this work again? This is a child with complex regional pain syndrome, sprained her wrist, and it took months to recover.
I could run that video on YouTube as The Exorcist.
Yeah, you could. It's a good one to show people what it really does. How much should you do?
Enough. I know you've been...
God! Sorry.
It's all
I was
right.
just going to say, I know
It's
that
all
you've
right.
been hanging out for a bit to make me one.
Yeah. You're beating it.
Oh no.
Oh, well,
It's beating me.
it looks as though you're beating it.
Beating you up, but you're beating
Yeah.
me up.
It sucks is I can't even get. I gotta give up and done, and then it stops. It doesn't. It just
Just keeps going till it's ready to stop.
Yeah. It doesn't matter if I want it to go on.
How my hands look. I see the difference. These ones are all big and puffy, and my hands are slow and you can't see any bumps, and I can't really turn them over and turn like that. And you see how puffy that one is. It doesn't move much at all. It's stuck in this position. I can get up and down a little bit, and I can move my thumb a bit today. This is like almost 2 weeks since I sprained it. I can do little movements, but otherwise that's it. So it looks a lot different to my other hand. These ones I can't feel at all, and they're kind of a bit kind of grey at the ends because there's not much circulation there. You know, these are really puffy. Tell us how you sprained it. I sprained it by being clumsy. Vacuum in the car, leaning too far with my arm like that, I want it forward.
That's why I should stop cleaning.
Yes, I'll never
Randall.
vacuum the car again. So there you go. So this is 2 weeks later, and this is how it looks. Sometimes this, does it look shiny at all? Yeah. This usually goes really high and shiny, and I get all these lines across because it's being stretched.
Regional pain syndrome works, but the one that makes the most sense to me is that in a crush injury, you damage the myelin at the site of the injury, and then even trying to move your hand hurts because it short circuits where the myelin is missing, and then you perceive that as pain. And she said her hand was numb, but it hurt a lot. That's what that numb pain thing again. That's an example of a child with complex regional pain syndrome. It used to be called reflex sympathetic dystrophy, and it was proven not to be caused by the sympathetic nervous system. It is caused by an error in the attacks are caused by an error in the vascular system, not the sympathetic nervous system. This is the drawing that that came out originally to explain reflex sympathetic dystrophy. We'll talk about that. What happens in diabetic neuropathy is the same thing that happens in eyes, and we're all over the eye thing where you have blood vessels that get compromised. You get these little blowouts, it's called microaneurysms, that break open, then you get microhemorrhages. If you get a big area and circulation fails and you wind up with a cotton wool spot, if you wind up with a lot of failure of circulation in the center of the retina, that's called cystoid macular edema, clinically significant macular edema, we got that covered front to back. We do that all day, every day. What happens in diabetes is that in the eye is the same thing that happens in the way periphery. The blood vessels have the nerves have a blood supply called the vasa nervorum. The vasa nervorum gets compromised in the nerves, in the way ends of the nerves, the same as it gets compromised in the eye. And as a result, these blood vessels fail, and as they fail, the nerves also have nerves. So the nerves have a nerve system with nociceptors that can detect that there's something happening to the nerve, and that's called the nervi nervorum. So you got a vasa nervorum that's failed, and the nervi nervorum says, hey, something's really bad, and that's what creates the burning sensation at the fingertips and the feet. And that's kind of like, and so this is the Lyrica. Lyrica is pregabalin, gabalin, and it defeats the pain at the spinal thalamic tract by inhibiting the pain signal. So does that hurt? It doesn't hurt. And the reason it doesn't hurt is you don't have any sensation left. All those nerves are toast. And then you wind up with damage, and you wind up with infections, and then you get your foot cut off, and that's the series of things that go on in diabetic neuropathy. So I think that this is what's happening to that second group of patients I was talking about, that you look at their eye and the bottom half of their cornea looks like hamburger. They got no complaints because they got no nerves. And what can cause that? Well, herpes can cause it, both zoster and simplex, LASIK, damage to the eye, chemo, surgery, diabetes, all of these things can occur in the eye as well. Also from the DEUCE 2, which made my job a lot easier because this came out in the summer of 2017, they described my two patients in the very first 2 pages of the description. So you have a presenting patient, in this case, that is asymptomatic. They have signs of ocular surface disease. What's wrong with them? They have dysfunctional sensation. How many people with surgery wind up with chronic neuropathic pain? Nerve damage takes place during surgery. As a consequence, significant numbers, 10 to 40% of patients experience chronic neuropathic pain, termed surgically induced neuropathic pain. And this exists in eyes. June 27th, 2018. Post-op pain could last months. Dry eye-like symptoms, and I'm going to talk about that for a second. Patients are not going to tell you that they have ants running over the front of their eye. They're not going to tell you that they have a stabbing pain like someone's hitting them with a cattle prod. They're going to tell you that they have a dry eye, because that's the words we use to communicate. So the category is dry eye-like symptoms, and that's what that new neuropathic scale that we talked about for the measuring pain, similar to the dry eye survey, that's what it leads to. So dry eye-like symptoms can persist 6 months after cataract surgery. A recent study found that 6 months after cataract surgery, 32% of patients continue to experience persistent post-surgical pain and have mild or greater dry eye-like symptoms. And 32% is way too high in my opinion, but if you ask the right questions, could you ever feel anything wrong with your eye? It's not uncommon for people to have a foreign body sensation for a super long time following their cataract surgery. Why doesn't cataract surgery hurt? You got a huge cut in the eye. Why doesn't LASIK hurt? Because you took those nerves off. What grows back? We don't really know. And in some patients, it's a cross signal that creates a neuropathic pain. This is from Review of Cornea and Contact Lens. I want to read you 2 cases. A 42-year-old man with a history of hypercholesterolemia underwent LASIK OU. He presented to Boston Foundation for Sight 10 months after detailed Timeline of his own clinical course as follows. Immediately following the procedure, he had burning sensation in both eyes. Within several weeks, he had noted symptoms of light sensitivity, halo effect, and extreme dry eye. He was initially treated with a topical Restasis twice a day, preservative-free lubricating drops, punctal occlusion. These measures substantially reduced his symptoms in the left eye 2 or 3 months after LASIK. Symptoms of the right eye persisted with notation of continued achy sore with tearing that worsened throughout the day, sensitivity to light, blurriness, and dryness. His symptoms in the right eye were subsequently treated with warm compresses twice a day, moisture changeable goggles during night, ointment 3 times a day, oral citrazine, trial of bandaged contact lenses, daytime patch, offering limited relief. Doxycycline 100 milligrams in mouth was prescribed for mild blepharitis. During this treatment period, the patient developed depression and ultimately was hospitalized for suicidal ideation, which he reported was caused by his eye pain. A 30-something-year-old female with a history of bilateral uncomplicated LASIK 2 years prior comes into your office complaining of persistent burning pain, almost a foreign body sensation in both eyes. A simple breeze across her face is excruciating. The pain is so severe it prevents her from living a normal life and she has thoughts of suicide. The slit lamp, though, is overwhelmingly unremarkable and free of corneal staining. Maybe she has a slightly variable tear function or reduced tear breakup time, but there's nothing to warrant her extreme symptoms. Patients go to their ophthalmologist, some of them suicidal because of the pain, and their eyes on slit lamp look perfectly normal. Doctors send them to the psychiatrist because they think the patients are exaggerating, which just adds to their burden. We see people with dry eye all the time. We see post-LASIK patients. Can dry eye cause neuropathic pain? From the DEWS 2 study again, it is reasonable to assume that when the tear film covering the ocular surface is thinned, a mechanical stress generated by blinking movements on superficial epithelial cells becomes abnormally high, injuring terminal nerve branches. This initiates a cycle of degeneration and regeneration, leading to altered architecture of corneal and conjunctival fibers. Reduced tear secretion leaves the corneal epithelium exposed to adverse environmental conditions. Osmolarity of the tear film increases. Excessive aberration causes rapid cooling of the ocular surface. Both lead to local inflammation. And you can prove it because they got a device that you can see it with called the in vivo confocal microscope, which is made by Heidelberg. I have a Heidelberg OCT. So I call my Heidelberg and say, I want one of these. How much is one? And he has no idea what I'm talking about, but he says, I know a guy. So the guy calls me and he says, you don't want one of these because unless you have a dedicated imaging person in your institution, those are the best pictures we ever got. And that's why you keep saying the same pictures over and over again. They're super hard to get. So I thought, well, that's unfortunate. I wonder if OCT can take care of it. In vivo high resolution human imaging using full field confocal optical OCT. They are able to visualize the subbasal nerve plexus. So what do you want in your next OCT? Okay, what do you want in your next OCT? You want something that checks, that finds Lewy bodies for you, for Alzheimer's. You want to know if the subbasal nerve plexus is damaged. And you want something that measures the lamina, and I'm not going to talk about that, but I think it's absolutely fascinating with respect to glaucoma. If we have time, we'll come back to it. So I think that's my other patient who has no signs of disease but has a ton of pain. And then that last category in the end there called neuropathic pain. So what's central sensitization? Pain itself often modifies the way the central nervous system works. Central sensitization is a condition where the nervous system that is associated with development and maintenance of chronic pain. Central sensitization occurs when pain follows the normal pathway in the downward arc. Pain nerves of the spinal cord reconfigure themselves to be more in a constant state of excitement and sensitivity. What syndromes are associated with chronic pain? The one we're most familiar with that we see all the time is fibromyalgia. In fibromyalgia, it hurts there, then it hurts there, then it hurts there, then it hurts there. And the definition of fibromyalgia at one time was you take a 4-kilogram device like we measured the mechanical one we used before, you push on any of these 18 sites, and if 11 of them are tender, then you qualify for the description of fibromyalgia. But they change all the time, and there's nothing wrong with the tissue. It's central sensitization. What else is involved in that? Some restless leg syndromes, chronic fatigue syndrome, some TMJs. There's a bunch of them. Irritable bowel syndrome winds up being one of them. Am I going the wrong direction? I am. I'm going to get the hang of this eventually. Dry eye syndrome, post-traumatic stress disorder, and depression in older male population. So I'll just take a second. The way the easiest to understand this is all of you rode a bike when you were kids. You get on a bike, you don't ride a bike for 15 years, you get back on a bike, and it's right there. You can get back on the bike, you start to lean, you know exactly how to do this. You have in your brain a bike loop where you're not going to fail. What's PTSD? PTSD is a fear loop. You have this horrible experience, and that experience is right on the edge of everything you do. If something happens similar to that, you wind up with this fear experience. Complex central sensitization is a pain loop. You are exposed to some pain throughout your life, whether it was a complex regional pain syndrome or a herpetic neuralgia or God knows what, and it creates in you this constant fear that you're going to wind up in pain. Central sensitization is a pain loop. Let's go to PTSD just for a second, and people know what PTSD is, right? Okay, we'll skip that. There's complex and normal. What percent of patients have PTSD? 50% of men and 60% of women have a traumatic event. So half the population has a traumatic event. What percent of people have PTSD? 8%. So if 100 people get in a train wreck, how many get PTSD? 16 of them. Right? Because they all experience trauma. It's not the 50, but it's 100 people. They all experience this trauma. How many of them get PTSD? 16. Can you figure out who they are? And the answer is kinda. And so this is also a TED Talk. So, and the story kind of goes, there's this physician who does a back surgery on hundreds of people. It's the exact same type of back with the exact same injury with the exact same complaints, and not everybody gets better. And he's whining about this to his neighbor who's a psychiatrist. He says, let's send him 6 questions. First question is, how happy are you with the outcome of your surgery? And then 5 more questions. When you were a kid, did you suffer physical abuse, sexual abuse, substance abuse? Were you abandoned, or did you have emotional neglect? And the graph looks like this. If you had none of these things in your past, 95% of those people were happy with the success of the surgery. If you had 1 or 2 of them, only 73% were happy. If you had 3 or more, 15% of the people that had the surgery were happy with the surgery, and the rest were not. Following that study was something called the Adverse Childhood Experience Study, the A study. The A study was done on a bunch of women who lost weight in Kaiser Permanente on the West Coast, and some of them continued to keep the weight off, and some of them failed, and they tried to figure out what the difference was. And the difference was the people with the horrible backgrounds were unable to maintain and keep their weight off. Since then, that A study has been applied to everything imaginable. Here's the A study. Question 4. Did you often or very often feel that no one in your family loved you or thought you were important or special? That A study has been applied to just about every other chronic disease we have, heart disease and lung disease. They do not recover well, even if they're treated. The background, is there, this woman goes through a description of that thing. Do people with PTSD experience more pain? Subjects with PTSD exhibited higher rates of chronic pain, more intense chronic pain, and more painful body regions compared to other groups. PTSD severity correlated with chronic pain severity. Emotional pain becomes physical. Do ACE scores affect PTSD? Do ACE scores increase the risk of post-traumatic stress syndrome disorder in U.S. Marines? The answer is yes. Is there a better scale than the ACE study to figure out who's going to wind up out of those 100 people that were in the car wreck, who's going to wind up, or in the train wreck, who's going to get it? And the answer is yes. It's called catastrophizing. And catastrophizing is exactly what you think it is. It's that patient who, when they went to the hospital, they had this happen, they had this happen, they give you blow by blow by blow, everything that went wrong. If they had a flat tire, it was the worst flat tire anybody ever saw, and the gravel got on his knee, and I couldn't find the jack. And it's that patient that reads the rare adverse effects in the Tobradex bottle and has every one of them. That's a catastrophizer. So a catastrophizer, because there's this thing called resiliency. So if you take high ACE scores and subtract resiliency, then you get catastrophizing. Does that make sense? And I have a whole description of this, but we're going to buzz through this because I really want to get to the end. We're going to skip that. There's pain catastrophizing, and we're going to skip that. Who gets them? People with fear loops and PTSD. So let's go back to eyes just for a second. So this study was done in Miami, and they took veterans that did and didn't have PTSD, and they're trying to figure out who had central sensitization. And their definition of central sensitization is that if you numb somebody's eye and they still experience pain when you tried to measure pain, that was evidence that it was central sensitization. It wasn't a peripheral pain. And the worse PTSD you had, the more likely and the more severe a numb eye hurt. Does that make sense? And we're going to skip that. Neuropathic pain due to dry eye is associated with multiple comorbid pain syndromes. Pains with more severe symptoms, neuropathic pain, report more frequent severe chronic overlapping pain diseases. So when we go back to these studies, the association between dry eye signs and symptoms are low and inconsistent. It's because dry eye is a symptom of their more severe disease. It's not the disease. And if someone comes in and tells you they have dry eye, put your pen down and pull up your chair and get a little closer and just listen and find out what else is going on. I have some examples, but we'll never get to them, of people that have with these problems, and they have these backgrounds, and you look at their drug list and it is extensive, and they all are taking Neurontin. They got a contract that they can only use so much oxycodone. If you're going to use as your success of a treatment the ability of whatever treatment you're going to use as dry eye symptoms, you're probably going to have a really hard time proving it, because a whole bunch of patients are not going to get better because they don't have dry eye. They have dry eye symptoms, but they don't have dry eye. They have complex regional pain syndrome, or they have central sensitization. And that was my point. I got about another hour. But that's where I wanted to get. Any questions? So I feel like I cut off the end there, and I didn't quite make my point. And my point is that when you look at dry eye studies and they observe that there is little correlation between dry eye complaints and dry eye findings, one possible reason could be neuropathic corneal pain. And secondly, the very first differential diagnosis in a patient with dry eye complaints should be, do they really have a dry eye, or are their dry eye complaints a symptom of a pain disorder? Good luck with your dry eye patients.